So hypothermia is one of those critical care conditions that occur from time to time, obviously usually during the colder seasons, but not necessarily, that is important to have a rigorous stepwise approach in order to manage these patients, because they often are quite close to death, and the things you do in the next half hour may make a significant difference in their probability of surviving. Before we talk about hypothermia itself, I want to just quickly go over some of the aspects of thermal regulation to make sure you understand how these things work and why we approach the management of hypothermia in the way we do. Thermal regulation occurs mostly through the hypothalamus. The hypothalamus is the central controller for heat conservation and for production, whereas most of the heat production is actually occurring at the muscle layer. All of the metabolic activity across the entire body produces heat. Even the most mundane sodium-potassium ATPase pump is producing heat. Now, we lose most of this heat through infrared radiation. About 60% of this actually is just radiated off directly as infrared. And most of this will actually lose through primarily the head and then also any exposed skin surface that's exposed to the environment. Conduction and convection, by direct contact and by air or water convection, accounts for about 10 to 15% of all of the heat loss, and then about evaporation accounts for an additional 25 to 30% of heat loss, and this occurs mostly obviously through the skin, but also through the lungs and respiration. The hypothalamus controls thermal regulation by primarily focusing on conservation and upregulating production when necessary. In order to conserve heat, what we'll do is vasoconstrict and keep blood flow away from the skin surfaces and keep it closer to the core. The hypothalamus can invoke behavioral changes like putting on coats or driven to get out of the cold, which are obviously the best ways to avoid hypothermia. The hypothalamus is also responsible for generating shiver and also non-shivering thermogenesis, which is primarily through the production of the burning of brown fat that's scattered throughout the body. Now, these compensation systems can work for as long as they have an adequate glycogen store. So shivering will only work as long as the muscle bed has a sufficient amount of energy and before the muscles fatigue. So the definition of hypothermia is any core temperature that's less than 35 degrees Celsius. We classify hypothermia into mild, moderate, and severe, and in this way we have a way of classifying and then approaching hypothermia and scaling up our therapies as necessary. Mild hypothermia is considered any temperature between 32 and 35 degrees Celsius, whereas moderate hypothermia is between 28 and 32 degrees Celsius. Anybody who has a core temperature less than 28 degrees Celsius is considered in severe hypothermia. Now, the only difference to this classification is in the case of trauma, where coagulopathies can be a serious problem even when somebody is not severely hypothermic. And in those cases, we actually define severe hypothermia anytime a traumatized patient has a core temperature less than 32 degrees Celsius, to help you really appreciate the importance of temperature management in this patient population. The etiologies of hypothermia can be divided into those caused by impaired thermogenesis, and this is primarily from illnesses or from medication effects. Increased heat loss, these are the environmental losses primarily, so the face down in the snowbank type of heat loss caused hypothermia. Also, non-environmental causes of increased heat loss can occur in the cases of being given under skin disorders like burns, where they're apt to lose a lot more heat quickly. The administration of cold solutions and IV fluids, and then medications or other conditions that cause diffuse vasodilation can all cause increased heat loss. Decreased heat production can occur in the case of malnutrition, when you just simply don't have the energy reserves to both shiver, and you don't have the fat stores to create non-shivering thermogenesis. And then there's a number of endocrine causes, particularly hypothyroidism, which can cause an inability to generate a sufficient amount of heat. And then finally, you can have inability to produce heat when you lose consciousness, and you then also, at the point of time where you're not conscious, you've lost the ability to shiver as well. The systemic effects of hypothermia can be divided up into mild, moderate, and severe, as we've previously discussed. Each of the organ systems listed, CNS, cardiovascular, respiratory, renal, and coagulation, are all increasingly influenced by the severity of the hypothermia. Mild hypothermia is unlikely to present in a critical care environment, as these patients are generally easily recognized, can complain of hypothermia, and are generally not as sick as enough to require our attention. They will frequently present with problems with judgment. They may be ataxic and have some problems with their memory, but at the same time they also have the classic findings of vasoconstriction, tachycardia, and decreasing total body fluid, in part due to a cold diuresis as under the influence of their kidneys. Respiratory rate increases and minute volume increases as part of the increased production of heat, causing an increase in CO2. And there's also a small increase in coagulopathy with a 40% loss of enzymatic function and some early platelet dysfunction, which is generally relatively minor and not something that you may notice in a non-traumatized patient. These findings in mild hypothermia may be present in somebody who has a traumatic injury, but the manifestations are that much more severe, especially as they relate to the problems with coagulopathy. Moderate hypothermia, however, causes a much more profound effect. They present with a decreased level of consciousness, and their pupils start to dilate. You start to see some early evidence of brainstem dysfunction. They have a decrease in their cardiac output now, not only from the results of a loss of fluid, but also now from actual myocardial depression. They may start to manifest some atrial dysrhythmias as well as bradycardia, and at this point in time of moderate hypothermia is the point where you're actually going to see the Osborne wave, if it's going to manifest itself. The respiratory system starts to also suffer as a result of the hypothermia at this point, with a reduction in their cough and an actual decrease in their respiratory rate. The cold diuresis at the kidney level continues to be an ongoing issue and further confounds the problems of fluid loss. Coagulopathies become even much more pronounced, with a further loss in enzymatic activity and worsening of platelet dysfunction. Once somebody's body temperature has dropped below 28 degrees Celsius and now are manifesting severe hypothermia, you start to see all of the effects of hypothermia that we generally will end up seeing in critical care. You start to see significant brainstem dysfunction that extends from a loss of some reflexes all the way to developing a flat EEG once their body temperature is below 20 degrees Celsius. The cardiovascular system is that much more twitchy at this point in time, and it doesn't take a lot to go from a sinus bradycardia to PEA and ventricular fibrillation, as well as just flat asystole. So moving these patients it has to be done very gently, because you can precipitate arrhythmias at this point. Often they're now apneic because of the brainstem dysfunction, and they may start to develop some pulmonary edema. The kidney function starts to fail, and you start to see the manifestations of malperfusion with acid-base disorders starting to manifest themselves. The combination of poor perfusion plus hypercapnia can make the acid-base situation that much worse. The coagulation system may start to then finally fail, and it can become both hypercoagulable as well as developing a DIC. So the management of hypothermic patients often falls into the realm of emergency medicine. Although you may be called in to assist in the management of these patients, especially as their hypothermia becomes much more severe and they become more obviously requiring critical care. There's a variety of different techniques for rewarming, and in this case I divide them into passive external, active external, active internal warming, and then extracorporeal methods. Now, passive external warming is the most basic thing, and it should probably be done with just about anybody who presents with any level of hypothermia. First and foremost, if they're wet, you dry them. Make sure that they're in a warm environment, and then if they have the ability to shiver, you should permit them to shiver because they can generate a fair amount of heat just on their own if they have the ability to shiver. Should cover their heads because that's where a lot of their heat is lost, and then also cover any exposed skin surfaces to prevent any further heat loss from those surfaces. Now, this is used primarily successfully in patients who have mild hypothermia, and it can achieve an average increase in core temperature of about half to 2 degrees Celsius per hour. And if this is not working, then it's time to move on to a much more aggressive methods of rewarming. Active external warming involves actually pumping heat into the patient using a variety of different techniques. You can use heating pads, as are usually readily available in most emergency departments, as well as external convection heaters to try to give them some additional heat. Some books recommend immersion in warm baths, but again, this is something you wouldn't likely see in critical care, as those patients should have a retained sensorium, and you wouldn't be throwing unconscious patients in a tub of water regardless. The advantage to this is that it can apply heat directly to the skin to both reduce any heat loss from the skin, but also to try to act as a source of heat to be taken up by the capillaries to be transferred back to the core. Under certain circumstances, you can consider using vasodilators in order to increase skin vasodilation to increase heat transfer, although generally I rarely see that done, and I probably wouldn't recommend that, especially if somebody has the potential for becoming hemodynamically unstable or if they're hypovolemic. Now, if they're hypovolemic and they're actually not warming up as fast as you would like with active external heating, you can use active internal heating methods, such as giving heated intravenous fluids, and then using other methods of lavage, either using gastric lavage, peritoneal lavage, and then as their condition is deteriorating and they require more aggressive methods, you can then start using mediastinal lavage with chest tubes. Now, these are specialized techniques and are something that should be done only as the patient's condition becomes that much more critical. They're at risk of developing cardiac arrhythmias, or they become profoundly unstable. Obviously, if they're intubated, you should ensure that the oxygen and the humidifier are set to higher temperatures to not only act as a source of heat, but also to prevent any heat loss from the respiratory system. The vast majority of emergency departments have access to heated intravenous fluids or have the ability to rapidly heat up a bag of saline or Plasma-Lyte. However, I should caution you about using excessive IV fluids because while some people may be volume overloaded, they could also be at risk of developing pulmonary edema if you flood them with crystalloids. And when you do give intravenous fluids, heated intravenous fluids, your amount of heat transfer is not nearly as significant as one would hope for. Generally, the heat transfer is in the role of a few calories and cannot be relied on as a primary method of rewarming a patient. When you start using lavage techniques, the stomach and the bladder, you should recall, are actually poor sources of heat gain because they're not very vascularized and they're not a high surface area, so they don't actually exchange a lot of heat with the rest of the core. As well, if you're using gastric lavage, you're placing the patient at risk for vomiting and aspiration. Peritoneal and pleural lavage, however, can be very effective in rapidly rewarming somebody, but you have to ensure that they don't have a significant coagulopathy before you start sticking them with needles. Peritoneal lavage can be done fairly rapidly with the minimal assistance of a surgeon, whereas the pleural lavage or mediastinal lavage can be done using a couple of chest tubes on a continuous infusion and drainage of warm fluids. The mediastinal or pleural lavage can be very effective in quickly rewarming the heart to both prevent and to try to have some direct effects on its cardiac output and its arrhythmias. Once the patient has developed lethal arrhythmias like asystole or ventricular fibrillation, you need to start considering the use of extracorporeal techniques in order to more rapidly rewarm them. You can use intermittent hemodialysis because you can achieve reasonably high flow rates of 300 milliliters a minute of blood, and then can rapidly rewarm that using a counter current exchange method in the dialysis machine. Using a femoral venous approach that's relatively easy to obtain access and then can actually gain about 2 to 3 centimeters Celsius per hour of heat just using that method alone. When the patient's developed a complete cardiac arrest, then that's actually a case where you may make an argument for continuous CPR and then conversion to some form of extracorporeal support using either ECMO or complete cardiopulmonary bypass. And this is probably the Cadillac of rewarming techniques because you can get the body rewarmed within at least quickly within an hour, and you can raise their body temperature 7 to 10 degrees Celsius per hour and get a lot of bang for your buck. Finally, in terms of using dialysis, using continuous renal replacement is theoretically supportable. However, the lower flow rates reduces the amount of actual heat transfer you can accomplish, and you're often better served just to go to an intermittent mode because of the higher flow rates. Now, as always, when you're watching somebody, even after you've successfully rewarmed them, you need to watch out for the development of a temperature after drop as the body temperature re-equilibrates and fluid is moving, cold fluids and cold blood are being transferred out to the skin or back into the core. You can sometimes see a drop in their temperature even after you think you've completely rewarmed them. And then you also need to watch out for the consequences of anoxia and poor flow, such as rhabdomyolysis and hyperkalemia, which can occur especially in the more severe forms of hypothermia. Now, as far as resuscitation of patients who are in cardiac arrest with hypothermia, the adage of they're not dead until they're warm than dead does hold. However, you need to make certain that you have a very solid story consistent with this. For example, in the past I've been involved in the resuscitation of a hypothermic patient who, after 4 hours of continuous CPR, there had been absolutely no success in getting them rewarmed. The initial story that we had been told was that they had fallen into the ice and then when pulled out of the ice were found to be in cardiac arrest. Now, the story itself was a little fishy because it's a rather rapid decline from being completely well and normothermic to suddenly being hypothermic and in VF. And when further queries were made of the family about the actual circumstances, there was a lot more clarity where they told us that they had seen the patient go into the water, they came out of the water, walked back to the truck to rewarm, and then after about 15 minutes, suddenly was found in cardiac arrest. The story doesn't quite fit. This is not somebody who's hypothermic and in VF as a result of their hypothermia. This is somebody who got wet and suffered, unfortunately in this case, a massive myocardial infarction. And at that point, we just terminated resuscitative efforts because we'd been doing CPR for 4 hours, and this was unlikely to get us anywhere. But if you can get the patient to tertiary care, continuing CPR, even for prolonged periods of time, may still result in a reasonable neurological outcome, and is certainly at least worth that effort to give it a try. So that's all there is for today. If you have any questions or comments, please feel free to leave them in the comment section below, or just contact me directly. Thanks for watching.